Welcome to Catalistas, the Beautiful Work Challenge. Coming to you from the temple at Catalista Centrale. My name is Sabrina Azul. The Beautiful Work Challenge is an audio kaleidoscope that illuminates the essence, the current situation, and the potential transformation of the world's professions. It all boils down to, what's the good of our work? This is On Birth, the transformation. Congressman Smith has been filibustering for over 23 hours. How much longer can he go on? Just get up off the ground. That's all I ask. Get up there with that lady that's on top of this Capitol dome. That lady that stands for liberty. Let her also stand for motherhood. Take a look through her eyes. You'll see the whole parade of what man has carved out. They tell us that birth has to be a surgical procedure. That physiologic childbirth is only for all other mammals. That contemporary childbirth is based on opinion, not evidence. You may not see respect or compassion. You may not hear the voices of women. You'll see a broken model of maternity care. Sure, it's a fight. But sometimes you have to fight for the lost causes harder than for any others. You think I'm licked. You all think I'm licked. Well, I'm not licked. And I'm gonna stay right here and fight for this lost cause, even if this room gets filled with lies. Somebody will listen to me. Chapter 1. Policy.
We were lucky in the late 80s where we had a very strong consumer movement, and actually America very much helped with the consumer movement, our bodies, ourselves.
Karen Gilliland was key to the campaign that gave New Zealand midwives the right to work autonomously, birthing babies without the requirement to have a doctor present. She served as chief executive of the New Zealand College of Midwives for 30 years.
So we had a very strong group of women, and in lots of groups, Save the Midwife and Maternity Alliance. We had lots of groups that were trying to change things for our maternity system. So the midwives themselves followed the women. It wasn't the midwives that changed things. It was the women who demanded a better service. And we happened to be in the right space when those women called for it. And then we happened to have a Minister of Health who understood what primary health was, who understood what women's rights was. And so together, those three things changed the law. And I think, when people say, how do you do it? Well, I think it's pretty difficult. It's very difficult to get those things aligned. And of course, there was a lot of resistance, not only from medicine, but, from a lot of mothers and mothers-in-law who didn't, who thought it would be terrible to have a baby without a doctor. But it really only took about 5 years for women themselves to think, actually, this is not a bad deal. Let's choose a midwife. And I think it really only took about 7 years for the vast majority of women to choose a midwife. Having said that, also, a lot of general practice GPs, we call them, the family physicians, I think you call them, they also were struggling to provide a maternity service and a much more consumer-driven primary health service. So being in your office and providing, a full range of services, plus being on call for maternity, became exceedingly difficult for family physicians, and the pay was lousy. So, it was just a combination of events that happened.
Carol Sakala is a longtime maternity care advocate, educator, researcher, author, and policy analyst with a continuous focus on meeting the needs and interests of childbearing women and their families.
I lead our work on maternal health and quality maternity care, and that is within our health team. I would mention that we issue selected resources that are widely used in our field. But I'd like to especially describe a key resource that we issued. It was a consensus document created by 17 national leaders, and it is called Blueprint for Advancing High-Value Maternity Care Through Physiologic Childbearing. And that report synthesized over 1,100 scientific citations. Basically, we were asking, aren't we missing something with all these high rates of starting labor in a medical way, driving labor along in various medical ways, ending childbirth in many medical ways? Are we missing something? Are we overlooking something? And we found from this report very powerful benefits of healthy physiologic processes around the time of birth that are part of our mammalian heritage. So they're innate processes that are within the woman's body and also within the actions of the fetus and the newborn as well. There's now starting to be actually quite a broad recognition that we should limit intervention to that absolutely needed, that we should support women in experiencing these bodily processes and not be providing elective procedures and so forth. The time is really ripe for taking this approach and trying to move our health system in this way.
My role is really to look at the economic burden of pregnancy and childbirth on women and on families and even in society in general.
Patrick Moran is a senior research fellow in health economics in the School of Nursing and Midwifery in Trinity College, Dublin. His research interests include cost-effectiveness analysis and evidence-based policymaking in health and social care.
The work I'm doing there is asking women about the implications of motherhood and the health problems that women experience and the costs of receiving the treatment that they need as well. We found that there's a huge underreporting and underdiagnosis and undertreatment of a lot of problems that women experience as a consequence of pregnancy and childbirth. And these are things like incontinence and mental health problems, sexual health problems, things that aren't necessarily easy to talk about. Women aren't asked about either by health professionals. And because of that, a lot of the economic impacts associated with them, aren't seen or felt by the health service. So it's like they don't exist almost. The consequences fall back on the women themselves, the children, the families, and a lot of it is funded through out-of-pocket payments could be decades after the birth of the child when the ramifications of these untreated problems are still being felt. From the perspective of efficient allocation of resources, what you would want to see is a market that funnels resources and care towards those who most need it and who have the highest propensity to benefit from it. From our interim results, that's not what we're seeing. But what we found was that across all care pathways, women at higher risk reported a poor experience of birth. I think the fact that higher risk women fare worse than lower risk women tells you something about the way care is organised at present. You have your first booking in visit at around 12 weeks and you exit maternity care 6 weeks after the birth of the baby. So what our data is showing is that time limited service really fails to deal with the health problems that women experience, because a lot of women, things like postnatal depression mightn't even be diagnosed, mightn't even arise in those 6 weeks after the birth of the baby. So, what you need is services that can extend for as long as they need, depending on the needs of the woman. And services need to understand and be more responsive to the differing needs of women, some of which might extend for a long time after the birth of the baby.
I love talking about the International Mother-Baby Childbirth Organization because we birthed out of a U.S. group that started in the 90s called the Mother-Friendly Childbirth Initiative. And that organization really developed guidelines that we call evidence-based steps that would complement
baby-friendly care.
Deborah Pascali-Bonero is a pioneer in reminding humanity that birth can be full of pleasure and delight. Deborah has trained thousands of doulas and birth professionals around the world in the practices of gentle birth support.
Many people may know that Baby Friendly is a hospital initiative that's geared to help mothers breastfeed. And what are the steps that hospitals can do and providers can do and communities can do to help with breastfeeding? But way back in the 90s, we started saying, well, what about the mother? Like if her birth is not good, if she doesn't feel satisfied with her birth experience, it makes it harder to breastfeed. So the US created the Mother Friendly Childbirth Initiative, and we decided, well, wait a second, the rest of the world wants to use it, and we don't want to be another group taking an American-centric initiative abroad that might not be culturally sensitive and relevant for their climate, whatever the resources, culture, religion was. So we did a great survey and worked with organizations and created 10 steps that are both entrenched in the research, the evidence, and made it culturally sensitive and relevant to use anywhere. So this initiative is kind of a guide. If you were to put together the best that science has to offer with both respect and a human rights framework, anything that you have options for in birth, you should understand not only what the benefits are, what the risks are, and what the alternatives are, and in a respectful way, be asked, what would you prefer in that situation? So we are both evidence-based, human rights, respectful care, and I like to add with compassion. I think one of the things we're often missing from maternity care when we industrialized and moved it into hospital, we sometimes lose the individual caring and compassion. I often say birth is like a conveyor belt and we're moving people through, and we forget to do that with love. So the International Mother-Baby Childbirth Initiative is now 12 steps to provide you as a woman, as a mother, as a partner, as a family, as a birthing person, with a template to say, this is the highest level of care, and I'd like to talk with my caregiver and find out which of these steps do you comply with, and I would hope the answer would be all of them.
It's easy to talk about public participation in research and getting women in and getting their views on what research we should be doing. And it's very hard to do in a meaningful way, and we've kind of embarked on a voyage with a lot of the women who were involved in the survey in order to kind of grow their experience and their skills in being able to contribute to that conversation and to input meaningfully into what research questions should we be looking at. And, in terms of what's important to women, who ultimately all this research is meant to benefit. We've got regular meetings where women participate in focus groups and chair sessions to look at these sort of questions with the aim of making sure that our research is directed at the things that are most important in the overall scheme of things, as opposed to, the most interesting research question from the point of view of researchers or funders.
Carol Sakala.
So what do we do with this information from this report, which is just so counter to how we predominantly support women and newborns at this time? A quality improvement leader named Paul Batalden has a really provocative, informative statement that every system is perfectly designed to get the results it gets. So we should not hope for different results unless we change things at the system level. If we want mothers and babies to be getting a different model of care, we need to create a system that reliably delivers what we would consider to be optimal care. And our new blueprint is just such a plan. We have identified 4 groups of women and babies who can benefit from this type of care, and actually adding up the 4 groups encompasses every single mom and baby. So our report is closely allied with many initiatives and approaches that are being widely used at this time. We identified 22 high-level recommendations that are arrayed across 6 strategies. I think that the blueprint really has something for every vantage point, every skill set, and every interest from all the people who are involved with or responsible for maternity care. Also, it would be helpful for people to bring this to the attention of policymakers, clinical leaders, and other decision makers because it has the force of a consensus document with many leaders in the field, names that would be recognized, for example, who have been involved with payment reform, performance measurement, clinical leadership, etc., health services research. And also, it's a tool for awareness, but there's still a ways to go. And many people assume that it is a very high performing system. And childbearing women, we know this from our surveys, they have a great deal of trust that they will get the care that is right for them and the best care. And they don't really understand some of the dynamics that are at play that lead to such a wide variation in the quality of care from one hospital maternity unit to another, from one obstetrician to another.
Doula trainer Deborah Pascali-Bonero.
We have a model of maternity care that I like to say is dysfunctional or broken. Other fields of science get current research and they strive quickly to implement it. But maternity care has fallen really far behind, where in many parts of the world, we certainly know around the world the best science, what the data tells us would be the best care for every mother baby. But many countries have not implemented it. They've kind of stayed in opinion-based medicine. We've stayed in a comfortable place of what we did has to be good, so why change it? And yet, I think we're at a time where we realize some of the things that we did with the best of intentions were actually harmful, and there are other ways to create better outcomes. So by creating the International Mother-Baby Childbirth Initiative, we really look at the science and we create a template of how can we get there. And what we know is we can do this in low resource, mid resource, and high resource countries. So I believe, and I know it's stretching for many people far, but I believe when you implement a true evidence-based model, you not only get better outcomes, which we all want on the health and well-being, both in the short and the long term of mothers, babies, and families, but we get the emotional well-being, which we're only in more recent years valuing, that women not only should survive, but they must thrive. And both components we should care about to build the foundation of stronger communities and stronger societies.
There's so many examples of really good research failing to translate into effective services, but having the political will and the advocacy groups and the women with a strong enough voice and groups that are empowered to shift the conversation from, academia into policy and into politics is really, I think, a hurdle that, if it was successfully overcome, would have huge transformative benefits for maternity services. And if you have any change in the way services are delivered that is interpreted as stripping away power or authority or income in many cases from a certain group of individuals and benefiting others, then you're going to get resistance from those groups. And often I think people, often with really genuine motivation, believe that what's in their best interests is the right thing to do. And not only because it's in their best interests, it's that from their perspective, from the way, they see the world, that is genuinely their belief that this way of doing things is the best. And it's very hard to extricate what benefits you from what you think benefits everybody. So I think what you need to do is not steamroll through this process where you say, we have this research here that's perfect and we know exactly what to do. You need to bring in all these voices into a conversation and let all these competing ideas and ideologies and opinions compete for the resources that are available and to make the case for doing things one way or the other.
Midwife Karen Gilliland.
Why aren't women totally in charge of their bodies? Why are they not involved in the decision making? Why, when you have a midwife who provides all that for women, is she not valued? What is it about the value of women's work that every country in the world doesn't want to pay for? So, our big struggle currently is pay equity. We've sort of won it. We won it in 93, sort of, when we got paid the same as the GPs. So what happened then, of course, and we knew this would happen, was as soon as the GPs left, our pay would wallow. And that's exactly what happened, because there is a social belief that women's work is less valuable than, say, traditionally male-dominated group like medicine or law or accounting. All of those things earn a lot of money in New Zealand. And we're saying, well, actually, we should earn the same. And we can prove that. We still don't have the political will to bring the money in to pay for it. And a lot of women too think it's a lot of money to pay other women. So, you're up against it when women also collaborate in the discussion that we shouldn't be paid too much. So it's a social thing, isn't it? I mean, midwifery would be overwhelmed with despair if you took that on, because as a midwife, one of the things that you can achieve for a woman is to make her feel that in this particular episode of her life, she was in charge of it and she did the best she could and she did well. And for some women, for the first time in their whole lives, they feel self-determined. They feel confident. It builds their confidence to be a mother. And if you're asking a midwife to do that very profound and actually highly sophisticated role, you can't expect her to change the world at the same time. So, you need political midwives. You need political people. I say this over and over. Midwifery is a feminist profession, but, as a feminist, it's on a one-to-one. We need help from external agencies and women's groups and the consumer movement to change society.
Welcome to the birth of tomorrow. Step right in and experience the future today. Here we have a group of women bonding. They are the champions of their own bodies. They are in charge. You may notice there's an even playing field between the women and their prenatal care providers. Let's step over here where we see a woman and her midwife, doctor, doula, and birth psychologist. That's right, the birth keepers speak to one another with respect. Listen to one another. A whole team devoted to both mother and child. On your right, you'll notice women provided with information, choice, birth justice, and guiding their own birthing process. This certainly is the birth of tomorrow, right now. Chapter 2. Practice.
So, Centering Healthcare works with clinical sites to transform healthcare delivery.
As Centering Healthcare Institute's CEO for 8 years, Angie Truesdale focused on spreading the centering model so that all Americans can have access to group healthcare. Angie spent much of her career on Capitol Hill with national health organizations addressing healthcare disparities and turning grassroots efforts into national movements for change.
We emphasize a movement away from didactic, quick patient encounters to a more facilitated group healthcare model. And what that looks like is that we come in and work with a practice and train their clinical staff and their support staff. And it's a little bit of reprogramming in many cases. The first piece is training those clinicians. And then we also work with the healthcare system, the underpinnings of the clinical practice, whether it's scheduling or billing or patient flow, to transform them to support groups of patients rather than rapid fire individual patient encounters. The clinical practices have the opportunity to form groups, cohorts of patients who have similar due dates. This is a bonded group that's going in together. And that includes the prenatal care provider. It's not drop in. So they go through those prenatal checks and the same schedule, but they're also able to dive deep into topics that influence the larger health of the pregnancy and the birth experience. Have you seen breastfeeding before? Have you not seen breastfeeding before? What are the cultural norms and myths in your community around breastfeeding? And can we make sure that at least the right clinical information is delivered in the context of those cultural myths versus facts? Talking about birth spacing before you give birth. What's your plan after birth and your goals for your family after this? And how much does your body need to heal? How much time does a woman's body need to heal between pregnancies to make sure that subsequent pregnancies are healthy and full term? Talking about stressors that influence the health of a pregnancy, whether it's employment insecurity, food insecurity, housing insecurity, transportation issues, all of that can weigh heavily on the minds of moms during their pregnancy as they're becoming parents and really influence the overall outcome of the pregnancy. So what you get is a bond among the group participants, but also a different level of trust and a different power differential between the clinical providers and the patients. By bringing them together in the group and having this extended patient visit, you're really getting to know these patients in a different way. There's not a lot of women who've gone through individual prenatal care and had the opportunity to connect with their healthcare provider on the realities of their food insecurity and what that means.
I'm Dr. Hakan Çoker.
Hakan Şoker is an obstetrician and childbirth educator based in Istanbul, Turkey. He's the co-founder of Birth with No Regret, a birthing team made up of an obstetrician, midwife, and birth psychologist. He facilitates training courses for doctors, midwives, psychologists, and doulas.
I'm an obstetrician and gynecologist, and for 19 years I was kind of a standard one. And then suddenly I came just by accident to childbirth education when I realized that we are doing something wrong. Because in that course, I noticed that they're talking about what woman needs and baby needs. So I started learning childbirth education and I took the Lamaze courses and hypnobirthing, and it changed my language so much. And then I met Janet Balaskas, Active Birth, and Spinning Babies, and they changed me a lot because I suddenly realized what midwifery really means for birth. In Turkey, in those days, which was 2006, it was the highest level of kind of cesarean rates. And cesarean was like a fashion, like Spain, like kind of like, especially in Mexico, in those countries, China, it started to be a kind of a fashion. So people who wanted a natural birth started finding it even from distances, from other cities coming to us. So 3-4 years, we worked like that. And then it was something missing. And I met Neşe Karabeki, who's a psychologist, psychodramatist, who also realized that in all her adult sessions, they started going back to the birth itself all the time. So she was trying to do something to change the world. So we came together and we arranged Istanbul Birth Academy in 2010, which is a firm which gives childbirth educations. And then after 1 or 2 years, we decided to we can share our experiences with others. And during that period, we started to prepare women together with her, which is not the first time for maybe Europe and US, but it was the first time for Turkey. So before that, they started working with birth psychologists and prenatal works. And then she decided to come to the birth itself. And this is what something is new. So first, it was a bit different for the clients, a birth psychologist and a private midwife coming together. So we arranged the team, but some of the clients didn't want it. It was something new because so we had to give a big decision. The decision was, okay, if they don't accept the team and the teamwork and what it is giving to the couples, we wouldn't accept the couples. So it was a very big decision for us because we lost nearly 60% of our clients. But I don't regret that decision because that started a new team called Birth with No Regret. And it was the doctor, midwife, and birth psychologist coming together, working together with the families. And in birth, they are all in action, respecting each other's proficiency, which was great work.
So this is a birth with no regret team.
Neshe Karabike is an individual, couples, and group therapist. As a birth psychologist and childbirth educator, Neshe trains psychologists, doctors, midwives, and doulas in birth psychology, psychodrama, and childbirth education. She is a co-founding member of the Birth with No Regret team.
I've been working psychodrama either to teach to psychologists or psychiatrists or to apply in individual and group psychotherapies. So now, since 2010, I am applying psychodrama either childbirth education trainings as like a games, warm-ups, and lots of plays. And also, when I'm working with the families, when I'm working with the mothers or fathers, I'm also using lots of psychodrama techniques. So, for instance, in our childbirth education, you as a mother or as a father become a muscle, or you become a hormone, or sometimes you become a doctor, sometimes you become a baby, so they can actually feel what they are feeling and what they are doing. For instance, why sometimes the muscle, the birthing muscle, circular muscles, doesn't open? Why? So they understand, then if there is a fear from inside, or if there is a lot of noise, negative noise from outside, then the muscles, just stuck. They don't open. So, it's easy to understand, with the theoretical part, but it is more effective if you really feel from your body. So this is a kind of a childbirth education part. So what I am doing actually as a birth psychologist, trying to understand about the family dynamics and the relationship between the husband and wife, and the relationship with the mother and the grandmother, mother's mother, and also to understand what kind of transgenerational information is coming from one generation to another generation, especially about the labor, about the birth itself. What is the perception? What is the belief? What they think about, what they believe about the births, babies, something like this. So when I get all the information slowly during the pregnancy, I am informing my team, my working team, who are doctors and midwives, sometimes doulas. Our education is actually kind of a doula umbrella. So when I say something, doctor also can understand, my midwife also can understand. It means I'm giving, little informations during the pregnancy, like, for instance, there's a kind of a trauma here in the family or in the mother or mother's, background, the past. So please try to not to say this or not to touch that way. I'm trying to actually open the path for my team as a psychological manner. And when I am doing this, I'm also supporting the team. And because, everybody was born sometime. Sometimes my team has got some trauma, or maybe midwives has got any kind of trauma. So I'm kind of trying to organize all these questions, all these past traumas, all these biases, all these fears, trying to make a balance. And sometimes I also participate clinic. Every couple or the pregnant lady needs to come to check, like a medical check every month to the doctor here. Not to midwife, interestingly, because it's a very doctor-based birth center here in country. So sometimes I go and attend to medical appointment so I can watch and I can observe also what kind of relationship.
CEO Angie Truesdale.
This is really hard on clinical practices to implement because it's requiring practices to slow down a little bit and think about how they present to their patients, what their systems and patient flow are like. Centering patients don't wait in waiting rooms, which is, if you've gone through a prenatal care period, that, you wait for about an hour and a half to see your OB, and then you have 10 minutes with them. And in those 10 minutes, they ask you 6 questions. You forget the 6 questions you had. There's some measurements and you're out the door. This is not that. We've heard of clinicians saying, you know what, I can't do centering because I can't care that much right now. I have too much going on in my personal life. I just need to do my work. And that's kind of how physicians have been trained, and the way our reimbursement system really incentivizes care right now. But something happens toward the middle end of day 1 of the facilitation training where there's a transition. And people just get it. They see it in action. They understand how the power dynamic changes for patients and what that can represent in terms of their trust, what they're going to confide in. What the research is showing us is that, it truly brings them joy. It reconnects them with why they went into medical care from the get-go. It wasn't, I want to see if I can see 30 patients in a day. Nobody goes in to early childhood care or medicine with that goal in mind. They want to deliver good care. And the care has been taken a lot out of our medical system in a way that centering provides a salve for.
Since the conception in 2010, we have shifted our work from being not just to support people giving birth, but also more of like advocacy, reproductive and birth justice work as well.
Ashley Hill Hamilton is a native of New Orleans and a mother of 3. Formerly the Advocacy and Outreach Director of Birthmark Doula Collective and the New Orleans Breastfeeding Center, Ashley has an extensive background in reproductive health and justice. She is currently the policy director at the Louisiana Center for Children's Rights.
So what reproductive justice is basically a person's ability to choose when to parent, how to parent, and on what terms. So it encompasses a full scope of things. We call ourselves full spectrum doulas. So that covers not only conception, it covers abortion, it covers people who have miscarried, persons who have chosen to adopt. We support families encompassing of all of those levels of the spectrum, including queer families. So the advocacy work that we're currently doing in New Orleans is a lot of people have heard about the issues that we're facing in our community surrounding maternal mortality and how women in general and Black women specifically have been left unsupported in ways that are often even resulting in death surrounding childbirth. So what we're doing in terms of our doula work is, one, we're on the front lines in the room with them, providing counseling, providing information, giving advocacy, educational resources to help with that. Also, behind the scenes, we're actually working attending city council meetings, advocating for a Department of Maternal Health in the city of New Orleans, which we lost after Hurricane Katrina. We've also supported people who have been involved with the criminal justice system, and this has been a contingency of them being able to keep their child. I say we do about 3 visits prior to the actual time of birth, but depending on what that client needs. We welcome partners to come into those meetings, and we just talk about where your greatest concerns are. We talk about your fears. We do believe that our bodies tell a story, and in that narrative, we hold things with us. Sometimes it may be traumas that we've experienced or negative experiences that we've had in our childhoods when we were teenagers, and all of those things are carried into birth. So we go on call for a week before and a week after. And what the on-call period means is I'm not going to go out of town. I'm not going to, stay up late at night for a party. That means that if you need to call me at 3:00 in the morning and say, hey, I feel like I'm in labor, I'm coming to you regardless of what I'm doing. And I'm literally on call. My life is on hold for that 3-week period. The week of your due date, the week before, and the week after, just to allow time. We also work with a backup system. So one of the wonderful things about working within a collective is you have other people to support you. So within Birthmark, we not only help each other with knowledge and information in relationship to a client that we're serving at the time, we also help each other with childcare for each other. So if I'm headed to a birth and it's the time I'm supposed to pick my daughter up from school, I can reach out to someone else and say, hey, I'm on my way to a birth. Can you pick my daughter up from school? And I have one of 11 people who's on call and says, yes, I can get her. Might be a little late, but I'll be there. So that feels really good having that support. So now Birthmark Doula Collective is a member owned collective. So all of us now have equal stake in the collective and are all member owners now.
Angie Truesdale.
First and foremost, we have exceptionally better outcomes. With Sittering, you see a flattening of the Black-white health disparity in preterm birth outcomes. And so what that looks like is a reduced incidence of preterm birth in the neighborhood of 30 to 47%. And that's huge. And if you can prevent preterm birth and the side effects that come with preterm birth, the long stay in the NICU, the respiratory issues, the vision issues that can come with preterm birth, in addition to mom being able to return to work and all of that family strain, then you can really change generations of economic stability and health of a family. So those outcomes are important. It sounds like one outcome, but the difference in delivering a 30-week baby and a 40-week baby is not 10 weeks, it's 10 years in terms of healthcare and productivity and family stress. So those moms become advocates for their own health and for their child's health from that way forward in a way that they likely were not before. What we hear from labor and delivery nurses pretty regularly is that they can tell centering patients on the labor and delivery floor just by looking at them. They're calmer, they're prepared, they advocate more clearly and calmly for themselves, and they have better birth outcomes. So that's a pretty powerful switch that's coming from the activation that comes with community building and interactive learning alongside of that healthcare delivery piece.
Ashley Hill Hamilton.
We really want a partnership with physicians. And in the years past to now, there have been significant shifts. And now we actually have some really amazing relationships with OBs. There's some that we're still working on and some who still don't understand necessarily the scope of the work that we do and what we provide and how we're not going against what you're saying, but we're here to work as a team. We're here with the belief that our clients can give birth on their terms. We're here with the belief that they're the expert of their bodies. And we just want to make sure that they feel comfortable, that they feel heard, that the care that they're given is not only trauma informed, but informed by the stories that they walk into the room with.
Obstetrician and childbirth educator, Hakan Shoker.
Now we have nearly 300 something births that we participated like this. We have no postpartum depression. All the interventions went down. Epidural use is 4%. Cesarean rate is like 7 to 8%, which is very low compared to 53% a year in Turkey. And the great thing is, which we are really proud of, and that changed the country, is the students we educated, they were also kind of activists coming to people crazy like us. They also took the fire and spread it all over the country one by one. And they started working with clients one by one, families. And now we have 450 students all over Turkey, and they are changing hospitals, they're changing doctors. That's the main thing. Because we also educate the other professions, like obstetricians come to us, and midwives and nurses and psychologists, they all spread the word. So once we say something, let's say skin to skin contact is important, let's do it. There are 500 people saying the same word, and it makes a big difference all over the country.
Therapist and childbirth educator, Neshe Karabike.
So if the labor stops, I'm there to support psychologically the family and my team together. My part starts before the medical intervention, before the induction or before the Pitocin or epidural or whatever. And I said, okay, let's see what is going on here. There is something wrong or any kind of fears. So I'm there to attend to kind of fix everything, because don't forget, I'm carrying lots of information, about the family and about the family dynamics. And then I'm trying to reply, or I'm trying to apply, let's say, okay, let's fix this. Let's do this. And sometimes I make a role reverse with the mother, the baby, and then I ask the baby, what is going on here? Why, you stop? Why you are not trying to come? Are you feeling something different? So this role reverse actually give us some idea about what the baby is feeling.
In Birth with No Regret team, midwife has responsibilities and borders, and I do have. So sometimes I listen to midwife, sometimes midwife listens to me, and sometimes we both listen to the birth psychologist because she knows the mother better than us. So respecting each other is the best thing we try to serve to the country. And they are coming together now and working together now.
So fortunately, I'm really blessed because I have my team here to understand what I'm doing and to accept what I'm doing. And also, the important thing is not only the less interventions, less C-section rate, but also the experience and the happiness or satisfaction is very important. And not only the parents, also the job satisfaction about the medical team or hospitals is also important.
From the Transpersonal Vision by Stanislav Grof, MD. Biological birth has 3 distinct stages. At each of these stages, the baby experiences a specific and typical set of intense emotions and physical sensations. These experiences leave deep, unconscious imprints in the psyche that play an important role in the life of the individual, reinforced by emotionally important experiences from infancy and childhood. The birth memories can shape our perception of the world, profoundly influence everyday behavior, and contribute to the development of various emotional and psychosomatic disorders. Chapter 3. Crisis. Karen Gilliland.
Even though we're nearly 30 years been doing continuity of care, the power of the media, the way in which women live in society, their rising rates of anxiety, their total lack of knowledge often around pregnancy and childbirth because there's no role models because we're in very small nuclear families now. We have got lots of studies, and what they show is that the power of the medical model and the media model and the place of birth can overwhelm any system that you have. So even though we've got continuity of care, the individual midwife can't always influence that if the place of birth is highly medicalized. And we're a highly medicalized country. You can't change somebody's whole philosophy just in one pregnancy. And often it takes 1 or 2, 3 babies. And unfortunately, in our society, we're only having about 1.9, I think, is our replacement value. So midwifery is constantly repeating itself, trying to show what the changes are, what you can do to have a normal birth. And the media, the social media input into a woman's pregnancy raises the anxiety level. It is bizarre, really. It's as safe as it's ever been in the history of the world to have a baby, especially in New Zealand. It's very safe to have a baby. And yet I think women are miles more anxious and scared about birth than they were 30, 50 years ago.
So I started in 2003. So after about 2008 or so, we started getting more and more and more people in very marginalized situations. So people without health insurance. So maybe people that were here without papers, or people that had come with a certain status and then that status changed and they still didn't have maternity care insurance.
Montreal Birth Companions was founded in 2003. Rivka Symbolist served as a director from its inception until 2016. The organization provided free doula services, prenatal classes, labor support, and postpartum care for marginalized families. She's the author of The Birth Conspiracy, Natural Birth, Hospitals, and Doulas, a guide.
In the first 3 or 4 years, maybe 10% of the people that we were serving did not have legal status here. And by the time I stepped down in 2016, it was probably about half of the people that we were serving. In the beginning, it was maybe 25 families a year that got to be 100 to 150 people that we were serving, some not physically, but giving them advice on the phone. I was also providing midwifery care for some of them, and through a kind of a network of unregistered midwives, which was really risky because basically practicing midwifery without being registered in the province you're in is illegal. So as it happened, those midwives have since been prosecuted for practicing midwifery without a license. And so that's not happening anymore. But that was happening for about 5 years. I mean, there are all sorts of questions that you could ask about that because, oh, why would they need to do that? Well, if you're having your second baby and it took you, 6 hours to have your first in your country and you're here without papers and you're probably going to give birth in 2 or 3 hours and you don't want to go to the hospital and pay a minimum of $8,000 to have your baby so quickly. And if there's a professional midwife who maybe isn't registered, but she's professional and certified, who could just come to your home and assist you, then why not do that? It allowed the people that were giving birth to be put in the center of the experience. And it just so happened that those people that were generally not in the middle of a pleasant experience at all, because they were people that were marginalized, didn't have enough food to eat. We right now have typical Montreal weather. It's icy and rainy and snowy all at the same time. And people would be from warm countries wearing little ballerina slippers in this kind of climate. And so our doulas would go there and they would care for them. I would rub people's feet. And any birth keeper that's listening to this would know what that means. You go in, someone's in labor, you do whatever it takes. And part of that might be you're rubbing someone's feet. And so for that person to come from often a really traumatic and horrible history and to end up in a country that they thought was going to treat them well and in fact isn't treating them well, and then to have someone come into the room, clearly much more wealthy than them and much more educated and all of those privileges that we have, and just get oil on their hands and rub their feet. It's radical and it transforms, and it doesn't just transform birth, it transforms the whole system.
When people say, how did you pick the Philippines? It picked us. We came over here because we were invited to come and try to help the mothers and babies stop dying.
Vicki Penwell has been involved with midwifery since 1980. She is the founder of Mercy in Action and the executive director of its clinic in the Philippines. Mercy in Action's focus is on maternal and newborn health and primary health care for children under 5. Vicki helped establish birth centers and practice in Idaho, Alaska, and the Philippines, as well as trained hundreds of student midwives.
So we're in our 28th year. In 2018, we passed the number 15,000. So by my calculations, we're somewhere around 15,260 today of births that we've provided in the Philippines completely free of charge to the parents. That seems quite miraculous to me because we started as a very small nonprofit. My husband and I have always lived very simply and low income, and it's phenomenal that we were able to do that with just the goodwill of donors, mostly individuals, people that believed in what we were doing from the very beginning and helped us do it. And the basis of Mercy in Action is really so simple, and it's amazing that we've been able to help so many people and have such good outcomes. Right now, our neonatal mortality rate runs about 4 times less than this country we're in. So we're saving a lot of lives. Our maternal mortality rate, when you extrapolate it out, it's about 8 to 10 times lower than the country we're in. And our methodology has been very simple. We use licensed midwives that are trained here in the country. We set up simple freestanding birth centers that are licensed by the Department of Health in our country, accredited by PhilHealth. So they're fully functioning, licensed actually along the same criteria as a small hospital. And yet they're very home-like. They're very simple. The births are very natural. And yet we have some really good low-tech emergency equipment that makes all the difference when there's complications that in a lot of instances, even hospitals in our country don't have.
Doula and author Rivka Symbolist.
My students had to do volunteer work to learn how to do the work. And part of what I teach is really you need to just sit there. You just really need to sit there because women's bodies are perfectly capable of giving birth, often without you doing anything. So don't think you have to do the hip squeeze or don't think you have to, run around with hot water or anything. If you're just sitting there and providing a loving presence, then many, many times it'll be fine. And that was initially my view. But as the volunteer program grew, I realized that actually that act of going to a birth and being available for a birth without being paid, and this is a really radical act because you're giving yourself, you're giving everything to someone who's doing a bigger job than you're doing at that moment, because giving birth and bringing other humans in the world, it's the biggest spiritual and physical act that we'll ever do. So if we're going to honor it, then we can't ask for $1,500 for it. Like we can, yeah, if the person can afford it, but it's such a radical act to do that, even if the person can't afford it. 2 years ago, a bunch of things happened around the world, and people started getting arrested for practicing midwifery without a license. And sadly, many of, the ones in Canada anyway, were taken to court actually by the College of Midwives, the College of Registered Midwives. We've been forced to battle amongst each other.
Bumi Sehat means Bumi is the Earth Mother and Sehat is healthy. So we're Healthy Mother Earth Foundation.
Ibu Robin Lim is a Filipino-American midwife and the founder of Yayasan Bumi Sehat, a non-profit organization in Indonesia. The clinic offers a comprehensive range of allopathic, holistic medicine, pre- and postnatal care, breastfeeding support, family health services, as well as gentle, loving, and natural birth services.
Our vision began with really trying to find a way to support human rights in childbirth, but we moved onward from there and just tried to fulfill needs. There's so much need, and it's not just in Indonesia or the Philippines, it's all over the world. All of our services are free or by donation, regardless of if you're a tourist or if you're a village person. We hope the tourists will subsidize the poor by giving nice donations. They don't always, actually, but they often do. In this culture, adat means spirit. We support whatever helps the families feel safe, whatever helps the mother feel safe throughout her pregnancy. She needs to be supported. And that means that if she is Hindu, she needs to know that her prayers are welcome in our childbirth center. She needs to know that as a Muslim, there are prayer rugs available to her. She needs to know that as a Christian, which are very marginalized people here, she's going to have midwives that when her baby's crowning are going to sing with her Christian songs. So we always sing when the baby's crowned here. For the Hindus, we sing Om Bur Bwa Swaha. For the Muslims, it's not really a song, it's more of a chanting prayer. We say Bismillahirrahmanirrahim, Allah Akbar. I find that there's a lot of prenatal scare rather than prenatal care. So we do our best to provide prenatal care without the scare. It just became very important to me and to my team of midwives that we provided a place for people to give birth and to recover and to be in labor that was wonderful and beautiful and bright and clean. Because everywhere you go in the world, if you really observe and look, from Haiti to Nepal to the Philippines to Indonesia, where all places I've lived and worked, I will say that most places provided for women to give birth in are, to be honest, shitholes. And we'd like them to be something nicer, something better, which is why we built in the Philippines.
Midwife Vicky Penwell.
So many countries in Southeast Asia, including the Philippines, we've been dubbed by the United Nations as a low resource, high mortality country. And it's the combination of having a lot of poverty, a lack of access to maternal, any kind of health care, really. We're on a system where people pay for health care. So a lot of the population can't afford to see a doctor or midwife when they're pregnant. It's the combination of being in a developing country where the systems don't always work for people, where there's not safety nets like there are in the United States of things like, welfare or Medicaid or things like that. So Sub-Saharan Africa and Southeast Asia are really the hardest hit with maternal mortality rate. And and newborn mortality rates in the world. In fact, those two areas of the world account for about 96% of all the infant and maternal mortality. All the developed countries together, US, Canada, all of Asia, Europe, Australia, New Zealand, those account for about 1%, and then Latin America for about 4%. And all the rest of it is spread between Southeast Asia and Sub-Saharan Africa. Not to mention the fact that the women we care for live on a garbage dump and make $1 a day at the most, scavenging. Some of them live in refugee camps and have nothing. It's hard when you see somebody that's living on such low income they can't even afford food or clean water, and then you expect them to save money for a birth attendant. The difficulty is birth is often normal. This is our difficulty. Part of the reason why we have so many women die in childbirth is because childbirth is not a broken leg or something else that you would know. We just have to borrow money and go to the hospital. Childbirth is so often normal that people will gamble on not going to a facility or hiring a midwife. And then if something goes wrong, it can go wrong really badly. Same with newborns. You can gamble that'll breathe at birth, but if it doesn't and you don't have someone that knows how to get it jump started, then you've got a dead baby, and it's too late by the time you drive to the hospital and beg and borrow money and ask someone to help you.
Midwife Ibu Robin Lim.
We've done disaster relief in childbirth. Here, after the tsunami, we still have the Bumisehat Childbirth Center and Clinic in Aceh. In 2004, over 400,000 people, if you talk to the military, were separated from their bodies during that huge natural disaster, the tsunami in the Indian Ocean. And in that heartbroken community, we still exist. We still maintain a beautiful team and a clinic run by the local people now. In the Typhoon Haiyan area in the Philippines, it's run by local midwives, totally been turned over to them, and we support them. We were in Haiti, we were in Nepal, Jogja, Padang, all of those earthquake sites. Right now, we have a permanent team in Lombok, our neighbor island, which was destroyed August 5th by a giant earthquake, the entire north side of the island. We saw over 3,000 sick and injured patients and pregnant mothers in Sulawesi right after the big giant 7.5 earthquake, and then the tsunami, and then the liquefaction. They had landslides, they had hail. They actually had a volcanic eruption on that same island during that time. Those of us who are birth keepers need to be aware of the fact that with climate change coming so strongly, we are going to see more and more of these natural disasters, and we're going to see more pregnant mothers made homeless and put in situations where they don't have adequate food, potable water, even light to keep them safe at night. These are all real issues coming up. The good news is I find that midwives are really ready and able to help.
Rivka Symbolist.
I believe that our culture is built on deadening things, on anesthesia, and not thinking and not feeling things. Because the young reproductive age women are so busy these days, they don't have time to think about what it means to give birth. So they'll just do it however they can. Just like, if there's a online grocery shopping, they'll do that. Or if there's like a labor saving thing anywhere, like anything that can save them time, they'll go for it. And with my blessing too, because there's no way that humans can really do that full-time job and full-time kids and full-time everything else and be sane. So the deadening is just part of the lifestyle that they can't manage it. But it's also part of what we're taught is that we're terribly afraid. And I actually do believe that we live in one of the best times that the human race has ever lived in. The other really disturbing thing about it is that I'm convinced that the fentanyl addiction explosion is because of the drugs that unborn babies are given through their mothers when the mother takes an epidural. People are born with drugs in their system. That's what they do.
Ashley Hill Hamilton.
So when we think about bringing trauma into the room, something like a really clear example that I give often is when we talk about vaginal exams. Every pregnant person, most female presenting people, when they go to a doctor's visit, you have like a pelvic exam. So you go in, you have this pelvic exam, and it's typically like the doctor, inserts a speculum, so on and so forth. But many people are walking into that with trauma, and it can cause them to relive that trauma if they have an exam and it's not done in a consensual manner. So we want to always treat people as fully human. We always want to treat people with kindness and care. people believe that persons of color have a higher tolerance, and it's actually in textbooks that women of color have a higher tolerance for pain. When people are being taught that in school, then what's happening is you're assuming that this won't hurt that person. You're assuming that this will, that this person will be fine with whatever this exam is, and not necessarily taking into account their past experiences, taking into account that maybe touching someone without asking them or having like this non-consensual experience for just such a routine thing could be completely traumatizing, triggering, have that person to tense up, even leave in tears, and then feeling as though they walked into a safe place and having like this negative view of that experience. I have had the pleasure to be able to kind of like hear both sides. And what we hear is a lot of people are not necessarily compliant with attending their prenatal exams, and that contributes to poor birth outcomes. But what we want to think about is, why aren't people attending their visits? They're not invested in their care. They don't care about their bodies. They don't care about their babies. But what are some of the barriers? One, transportation. If you live in a rural area, you just may not have a car. Or if you do have a ride, you may have a ride that one day you have to choose if this person is going to bring you to pick up your kids from school, or you have to choose if they're going to bring you to that doctor's appointment. Another thing is thinking about people who have been introduced or re-traumatized or treated, like I have to say, like less than human, or not given all of their rights, or felt like they were intimidated when going somewhere. And then this negative association is developed maybe with that place, even if it didn't necessarily happen with that person in particular or that provider in particular. And this is seen as a place that I want to stay far, far away from. So I think all of those are things that can re-traumatize people, things that can like inhibit or impair their willingness to want to seek care actively. They're not feeling safe, not feeling comfortable.
Vicky Penwell.
From my perspective in a developing country, which I don't know if is really different even than what needs to happen in America, but I think we need to remove barriers to good care. And I think that part of how we do that is figure out how to make birth affordable and available to all pregnant women. And we are struggling with that everywhere in the world, how to do that. I'm not saying I have all the political answers or how to figure out how to afford universal health care or all that, but I know that we should be able to be creative enough to come up with a way that the lack of money is not a barrier to survival in childbirth. I think that's one of the first transformative things we need to see happen everywhere, is for people to figure that out. We've proven for almost 30 years that you can figure out a way without spending a lot of money to make it affordable. I think that's the first most important thing. But second of all, we always have to remember that second barrier, because until probably the last decade, we didn't realize what a barrier it was for people getting care of not being treated kindly. And yet we found it really was that people won't go to a facility to give birth. They'll stay home and take their chances with no attendance at all, with no backup or emergency, anything, if they feel like they'll be disrespected or even abused. Harvard is studying it. World Health Organization is studying it. The White Ribbon Alliance has an entire section on abuse and the actual act of giving birth, actually in a facility where people are being abused. So it's come to the forefront. It needs to. We need to talk about it and remove that. I mean, it should never happen. It shouldn't happen that women have to worry about that while they're also worried about going through contractions and, making it through labor. So those two things, I think, though, removing those barriers of cost and of disrespect would transform birth. We have a nonprofit clinic, Mercy in Action does in America also, and we see the same issues there, barriers of respect and of money. And so our nonprofit birth center in Boise, Idaho is making a huge impact too, and we're having really good outcomes by removing those barriers.
Ibu Robin.
If you look in the archives, the UN made a beautiful animated video to try to help midwives all over the world be nice to people and not slap women in childbirth. I've seen doctors and midwives and nurses slap and punch women in childbirth in hospitals and tell them to shut up and not make a sound, and tell them that, well, if it didn't hurt when your husband was putting the baby in there, why are you crying now? Terrible, insulting violence in childbirth. There's a lot of that. There's an entire movement that friends of mine are spearheading to give women a chance to speak about the obstetrical violence that they experience And we're doing a lot to change it on a large scale because we're available to everyone here. Anyone can walk into the clinic. We need to bring love. And when you bring love back into medicine, you bring healing automatically. I mean, I believe that if you give someone a glass of water with love in your heart, genuine love, you're making them better. I mean, look who's doing the real healing in the hospitals. It's those nurses that can put an IV in without the patient even feeling it. It's just amazing to me. We need our health authorities at the highest level to be mothers. And in fact, in the Catholic Church, we need to get rid of all the men and for a good generation or two, have only women running that church, only women giving the sacraments. And I say that as a Filipino raised as a Catholic, who's also a practicing Hindu. I really feel like it is the time, it's the day and age of mothers. I don't care if you're walking around in a male body. You better be walking around talking and listening and loving as a mother would. You know, when you practice love, I mean, I have some pretty irritating people come into the clinic, you know, Russian guy who says, if something happens to my wife or child, I kill you. And you go, really? You think I don't kill people in my own country? I kill plenty of people. How do you love that guy? But he's having a baby. You teach him not to say, my wife is having a baby. You teach him to say, we're having a baby. And how do you do that? How do you teach a hardened criminal like that to say, we are having a baby? You remind them that the baby's listening. The baby's always listening. Those of you out there that are birth keepers, never assume that the mother that comes in to see you for a prenatal care or just a meeting maybe with a doula, to get to know a doula, never assume that mother that has come in to see you has got the love she needs at home. So that means it's even more important that we practice with love. If you love her, you could be that one person that believes in her. If one person believes in you as a pregnant woman, you know, that's going to help you believe in your baby. That's going to help you believe in your partner. That's going to help you believe in your healthcare providers. And when you speak to the medical professionals that are in authority, for example, the doctors in hospitals, the people running the hospitals, the administration, speak to them with love. You know, remember, water wears down the stone. You know, the fact that I can go to any hospital in this country and be treated with respect is because I just love the heck out of those people. And they were not very lovable. But love, because when someone speaks to me with hatred and anger, I have to protect my heart. And when I protect my heart, my ears close and I can't hear what people are saying. But when people speak to me with love, I'm wide open. I'm learning. I'm taking in what they need to say to me. And I'm listening.
Welcome, everyone. Welcome to the Catalista Centrale Cafe. It's wonderful to have such a nice turnout for this evening's podcast and conversations. Before we start, I want to mention some of the groups who came to listen tonight. Let's see. We have students from middle school and high school. And it looks like some interns from the medical school have been listening to our show. Woo-hoo! Even a few doctors are ready to hear what's going on. I'd like to welcome the moms, dads, and families who are with us. It's wonderful to have you here. This is what it's all about. Ready? It begins like this. Chapter 4. Education.
APPA is Association for Prenatal Perinatal Psychology and Health, and we have an online education program.
Kate White is a perinatal educator and trauma resolution professional. Her work combines somatic therapy, birth preparation, and trauma resolution. Kate has been involved with pre- and perinatal health for over 25 years.
Our centerpiece is 11 modules. So the paradigm is that babies are aware and conscious. So they come in and they have experiences. They have relationships with their mothers and their fathers and their surround starting in utero. So our 11 modules are birth and bonding, breastfeeding, the foundation of our history, ethics, epigenetics, neuroscience, which is important around the developing nervous system and what that means for us. And then our psychological theories, which are changing to include the body, and then culture, which is profound. And we talk a lot about the adverse childhood experiences and some of the things that have impact. So those are the 11 modules. And then we have a conscious baby program for parents. And we're hoping to really help walk parents through, if you wanted to have this paradigm really in your belief system and in the way you conceive and carry and birth a baby, what does that look like? So we have interviews with parents, and we have interviews with professionals, and exercises that you can do to reflect and actually communicate and contact your baby, and ways you can make choices. And then we have tools for professionals. So people who want to help others create the conscious babies and the gentler births. So we have toolkits that we're developing. Our first one is for parent educators, but we have a lot of plans in that domain. A lot of what we need to do is help our young people trust their bodies and really feel safe and sacred. I think there's a lot of mystery that still stays in this period of time, birth and preconception and prenatal time. It lies in mystery still. We haven't figured everything out, and I like that. But to help humanity, working with our youth, to help prepare them and help them make choices that include that the baby is conscious. Can you imagine something like this in public school or in our families, where we help our adolescents cross the threshold into adulthood and say to them, you have a great job ahead of you to call in a spirit or a soul and a baby, and then really be present to that baby. And in this way, it could change humanity, truly.
Deborah Pascali-Bonero.
I would love to see education about birth in high school curriculums to really look at not only the process itself, but the emotional component and what does it take to have a respectful, safe, and satisfying birth. Because I think if every person, man and woman, knew that information in a school setting, then if and when it became their time to bring new life into the world, they'd at least have a basis to ask questions. So many people today around the world in birth, we don't know what we don't know. And so many people don't know enough to even ask the kind of questions that are needed to make sure that they're receiving quality care. Their education system in the university dramatically needs to change. Again, we're training students, nurses, midwives, and doctors in a paradigm that's still heavily technocratic and not integrating the person into it, not bringing that respect and dignity, and also looking at all the natural alternatives that we used to say, those were those crunchy granola people with natural births. We're now understanding that the physiology of birth matters, and that there are many ways to encourage the natural flow of the hormones, and that makes a difference short and long term. So we need to look at having our caregivers see this. Many doctors today never see a physiologic birth, and it makes sense because they're well trained in technology and interventions. That's their priority. But I wish they had a little bit more education.
Hakan Shoker.
Medical education, I think it is still the same. They teach you pathology. If we teach them even 4 hours, 5 hours, real childbirth education for them will change them. If they see a baby being born in a physiological way, even from a video, they will change. But this is not being done. I mean, this is the missing part of medical teaching levels. So maybe doulas should go and sometimes give them lectures. I know it sounds different, but today some of the obstetricians learned from doulas about the feeling of birth, the way they look at birth, the way they support birth. They learn from them, which is normal.
Perinatal educator Kate White.
The first thing would be to support our hospital staff to help them feel more care and more reflection upon what it is they're doing and how they feel inside themselves. I think that if we educated them and had ways that we could go in to their hospital settings and say, this is what needs to happen for there to be a real welcoming of this kind of conscious birthing. And that means really bring attention to the interventions that we use.
Ashley Hill Hamilton.
There's this confidence, this arrogance sometimes that medical professionals enter the room with of like, I'm the expert. I know what's best. And it's like, yes, not to discredit or take away at all from like all of the great knowledge that you have, like the years and years and years that it takes to become a medical professional. So yes, like we acknowledge that, like we do listen to your expertise. However, you cannot read the story of a person's life.
Nashe Karabike.
Turkey, unfortunately, is the very first country in the cesarean rate. So slowly, we have to enrich the perception of doctors, especially in my country. I know there is no any kind of lessons or any kind of classes in medical universities related with birth psychology, prenatal and perinatal psychology, and also how and if whether the babies are recording, if they really understand something in the womb. They don't know anything about it.
Ashley.
What I always look for is not necessarily the person with the most experience, but I'm looking for the person who has like the most open mind and the person who is open to saying, okay, maybe I've seen this exact thing 12 times, but I know that you as person number 13 could be completely different. Even though it looks very similar to all of the 12 cases that I've had, I know for a fact that case number 13 could be slightly different.
Hakan.
I think the best standardization will be in the future is childbirth educations being evidence-based first and following the rules of mother-friendly hospitals, which are all evidence-based anyway. So once we do that, if you imagine all over the world, all hospitals has to give education with that, then all the mothers will have the chance to learn their rights and they will learn how to ask it from the system. Otherwise, they will still be the slaves of the system.
And I think the answer is pretty simple. Treat people as being human, be nice, smile, have a nice candor. Let's start there. I would say start there by looking at everyone as being fully human, not looking at someone by their circumstance, not looking at someone in their environment or what they're going through or having these preconceived notions of what they're capable of, what their desires are, what they may want, but genuinely looking at this person as if you were looking at them.
Childbirth education makes women to realize their rights about birth and to fight for it. And if we teach them to fight for it with respect, not aggression, then they change the systems one by one. I'll tell you a story, for example. I mean, in 2011, waterbirth is still very new in Turkey. And one of my clients said, I want waterbirth. I bought the pool. And she said, where can I use as a hospital? In Turkey, 60% of the births are in private hospitals. I said, you can ask administrators to accept you. So she asked, one hospital accepted it. And now we all go to that hospital for water births. She changed the hospital to accept water births. So one by one, if we change women, then the birth will change already.
Vicky.
I'd also like to see there be a global awareness that everyone is aware of the disaster we're having over here in the developing world with birth outcomes. I think something people can do right away is to educate themselves. Mercy in Action in early 2018 launched a diploma program for health professionals that are involved in maternity care. So it's for midwives, doctors, nurses, doulas, childbirth educators to be able to go through a diploma program in international maternal child health and learn about the issues of their sisters across the sea, as it were. And we're seeing a real transformative power in that. People that thought they knew the issues are finding out halfway through the diploma program that their eyes are just open. It's making them more responsive to sharing, going and teaching or sharing even their resources, the tithing, a part of their birth, fees to go to people that are working in third world situations. I mean, it's hard for them to know. Excited is maybe the wrong word because at first people feel quite heartbroken to find out just how bad it is and just how many mothers and babies are dying in childbirth and just how bad the situation of women is in much of the world. But then there's a real excitement that they feel like they can do something. They feel empowered to help. And I think that's what we all need. We can't just hear about the problems and not have an avenue to help, or it can make us a little crazy. So I think getting more educated, finding a place to volunteer, whether it's time, money, teaching, and then sharing the information, being able to feel empowered to help the rest of the world kind of come up to that awareness that we're still losing more mothers and babies in childbirth than we're losing in wars or natural disasters in the world. And so when we start thinking about it like that, we'll start having different kind of behaviors, I think, because it is a crisis. It's an absolute disaster.
Kate.
The next thing is to really prepare our families with education about baby consciousness, helping our parents communicate. We know that a lot of parents bring their own history with them. And so helping parents reflect on their own parenting styles, their own early history, their own adverse conditions, their own levels of stress. We know that stress really is a huge deal.
Neshe.
We need to educate parents to take the role of their processes, their experiences, birth experiences. And also they need to understand this is their birth. And this is not a medical thing, And so if they understand and if they create this kind of perception, then they can also stand up and they support their births to support the parents' power and also the mother's power and respect the baby's feeling and baby's perception and baby's existential there. So this, it seems it's a little bit hard work, but it's worth. We need to do this for babies and we need to do this for future, for sure.
Deborah.
We need more classes in our community. I think it's wonderful that hospitals offer childbirth education, but we know today many people are not accessing that. It's often not where people feel safe to learn. We need to bring it back into community.
Rivka.
A very simple one is to allow and create and somehow make happen physical spaces where people can get together to talk about birth, after they've given birth or before they give birth or when they're breastfeeding. The activity of birth and parenting isn't out there enough. It's in people's homes. It's not in communities, and people are not talking enough. I don't work in birth anymore. I run a little cafe now, and I have mums coming in all the time. I like it when my place is full of all people of all generations, and that's how it should be.
We value each woman as a strong, creative, unique individual with life-giving powers. We value the process of labor and birth as a rite of passage, with mother and baby as equal participants. We value the essential mystery of birth. We value our right to practice the art of midwifery, an ancient vocation of women. We value the art of nurturing the inherent normalcy of pregnancy and birth as expressions of wellness in a healthy woman. We value birth with a midwife in any setting that a woman chooses. We value a mother's intuitive knowledge and innate ability to nurture herself, her unborn baby, and her newborn baby. Extracts from the Midwives Alliance of North America Statement of Values and Ethics. Chapter 5. Transformation. Ibu Robin Lim.
We have to think beyond the baby being alive and the mother being alive. We have to think about health, optimal health, and healthy family. How is that baby going to be nurtured into the future? How is that mother going to be supported as a mother into the future?
Carol Sakala.
So I personally have understood for a long time that we need a transformed maternity care system, that tweaks at the margins are not going to give us the care that childbearing women and newborns need and deserve and what is possible.
Angie Truesdale.
Really, it comes down to an acceptance that medical encounters do not equal healthcare. These are not one and the same thing. And if we're going to have healthy babies and healthy families, which require a healthy birth experience, then our system really needs to look at the whole patient lived experience and how that contributes to their health.
Patrick Moran.
Problem, I think, up to now is that the voice of women has been silent in a lot of these conversations, which is a really terrible situation, really, because ostensibly the whole conversation is about improving outcomes for women, but they're often the least heard in all of this. And as I said, it's not always easy for them to contribute. So we need to empower and nurture women so that they're able to partake in these policy debates. But also we need to listen to obstetricians, and we need to listen to midwives, and we need to listen to the evidence-based cases that they can make for doing things a different way or developing policy in one direction or another, and then try and choose the best way to proceed then.
Deborah Pascali-Bonero.
I think what's really important is that we have collaboration and engagement of everyone. I think so often in the past, we've done things top down, whether it's government down, whether it's facility down. We make decisions, and the stakeholders, the people that are affected by the care, aren't at the table. And I think that's been a huge mistake in society in general, but it's really been a mistake in birth. We haven't been really listening to women's voices. We're only beginning now to do surveys and asking women what they want. What did they get what they wanted in birth? What didn't they like in birth? What do they want more of?
Vicki Penwell.
So it's interesting that we're having the debate we're having in the United States, because everybody is really arguing over that, whether healthcare should be a right or is it a privilege. Most of the people working in international maternal child health care and working globally, they've already solved that. They feel like surviving childbirth is a right. Maternity care should be free. Whatever you do with the rest of healthcare, maternity care should be free of cost to the user, because when a woman's in labor, there's not really time to go get money. It's really, really pretty urgent.
Angie.
We're seeing some of the best innovations to fund this kind of care within the Medicaid system. And that's really where we're seeing the best outcomes. Believe it or not, the most flexibility. There is the ability, by having that overarching single payer umbrella, to innovate and meet community need in a way that kind of a fractured private payer driven system doesn't have, because it's about competing bottom lines rather than outcome.
Vicki.
I think when we think of disasters, we think we're helpless, but we're really not. There's so much we can do to help. If we treat it like disasters, we will think differently, because when someone is buried in the rubble of an earthquake, we don't ask them to pay for their rescue. We just go do whatever we can to get them out alive. And I think we're at that place with birth in much of the world. We need to start thinking that way.
Rivka Symbolist.
My vision of where births could go is really influenced by my knowledge of how so-called volunteering makes a difference. As soon as someone does that act of attending a birth or doing a prenatal thing or going and washing dishes after someone's given birth, and not a friend or a relative, to someone that you don't know, as soon as you do that without expecting payment, then I believe that you're making a little tiny brick in that path that we're making to a radical transformation of birth. I don't know what it is about it even. It's something about the humility in front of that bigness and honoring that person, no matter how different they are from you. It makes a tangible difference in the world. And so professionals, so that would be students, and go and start a volunteer doula program. I'm here to help. Email me, I will help you set one up. I'm all over it. But start a volunteer doula program, and don't listen to the people who say that you're undermining your value, because you're not. There's a song, it's a rap song called Blessings. So he says, I don't sing for free, I sing for freedom. That's what you're doing. You're not providing your doula services for free, like if you want to look at it that way, but you're doing it for freedom.
Kate White.
Many birth professionals are struggling with their own experiences as a professional. Birth is a beautiful, amazing thing, but it's hard work for the professionals, quite frankly. Giving them support, helping them feel safe and supported in their bodies will make a big difference, I think, in the birth process as well. So many times at the birth, people will make decisions about position of the mom or what kinds of interventions to use. So we need to do a lot of long-term education about the impact of these interventions on this process and how this process of birth and those leading up to birth are all pivotal, vital places. And you can make different choices if you bring consciousness to it.
Ashley Hill.
So I can't tell you what to do with your body. A lot of people have preconceived notions of what doulas do or what we believe. I believe that people should have autonomy over their birth experiences, period. I don't believe they should birth this way. I don't believe they should birth that way. I believe in whatever decision they feel is best for them and supporting them and empowering them to do so. So that feels really transformative in a world where we're always being told what's right, what's wrong, what's proper, what's not, what's best, what's not. And we're walking in completely as an open vessel and saying, hey, what do you want? What makes you most comfortable? Here's the education, here's the knowledge, here's the research, here's the evidence supporting what you're saying. So I will give you information surrounding what your desires are, but I'm not in any way, form, or fashion going to tell you what you should do. Just in general, women are often told how they should live, how they should dress, what they should do. It feels really good being able to be in a position to tell people, hey, it's whatever you want. Tell me how I can help you make it happen.
Hakan Shoker.
In Turkey, the problem is they don't take our doulas into their dirty rooms. They say you can support the woman in the labor, but I will not take you into the dirty room. What I believe is that room does not belong to the doctor. That room belongs to the woman. The woman pays and hires a room and decides who to come in. I mean, they are lucky that they chose him or her, the doctor. She could have chosen a different one. Practically, once you choose a hospital, you choose the doctor and the midwives, and you give them right to go into your room. That's practically the woman's room, like embassies. Another country cannot go to the embassy without permission. I believe there, but the women do not realize this yet. Once they realize it, then they will give permission to people they need to, and doula will be one of them.
Nashe Karabike.
So sometimes, maybe until we really educate midwives properly, we need doulas to support parents as a one-to-one support, because otherwise they are so lonely. They don't have anybody with them. So that's why doulas are important. So the other things about the birth psychology, we don't know it really. We don't know what it is. Prenatal psychology, perinatal psychology, and also postnatal psychology. Not only for the parents, but also for the doctors, for the midwives, for the birth keepers. Because really, they have also lots of traumas. We need to clean about our past traumas and about our past stories. That's what our aim is.
Karen Gilliland.
There's not much a midwife can do other than try and do the best with that particular family. And we can prove we've made an enormous difference over the years too. But I think, one of the things we're sort of doing is we are providing women with that very confident birthing at the end. It's 6 weeks postpartum. We are providing women with an experience that makes them question more, that makes them maybe more confident. Those are things that are quite hard to research as well. But my impression is that New Zealand women are quite stroppy. They're not afraid of speaking up. And I think we've helped that. I think we've helped them keep like that.
Ibu Robin.
So this is a really important time for those birth keepers, especially you next generation younger birth keepers. Thank you for your devotion to this revolution. Thank you. It's not an easy path. It's an uphill path, and you might be demonized at times, but just stay on it. You have a tremendous opportunity to fight this battle with a special weapon, and it's a woman's weapon. Your only weapon is love. You don't need your anger. You don't need your hatred. You need your passion, yes, to study up and find out, what your activist role is. Read about these atrocities and find out what resources women have in the world. Make it happen. Make it happen for your generation. I'm really sorry that my generation didn't really achieve what we hoped to achieve. I'm sorry about that. I'm still working on it, and I'm not going to rest until this body is expired.
Thank you for joining us for the Beautiful Work Challenge on birth.
And thanks to our transformation guests, Karen Gilliland, Carol Sakala, Patrick Moran, Deborah Pascali Bonero, Angie Truesdale, Hakan Shoker, Neshe Karabike, Ashley Hill Hamilton, Rivka Symbolist, Vicky Penwell, Ibu Robin Lim, and Kate White. Special thanks to everyone who subscribes to Catalista on Patreon, where contributors can access merch and bonus birth interviews. The Beautiful Work Challenge was edited by Tim Kirby and Kajsbert Umboshir. Sound design is by Rich Cutler and Jay Blanchett. The mix is by David Tedesco, with assistance from Kajsbert Umboshir and Mark Tolk. Our music is composed by George Jennings. The executive producers are Chicky Munch and Binny Bunny Munch, with assistance from Ed Goldberg, Nikki Hatzidis, and Gerald Gerbil. You can find the current schedule of Catalista podcasts and sign up for our weekly email at catalista.net. If you enjoyed the Beautiful Work Challenge, please add, comment, and like us on your favorite podcast platform. This is Sabrina Azul, signing off from the temple at Catalista Centrale. See you next time.